Well, for those that are here and those that I know are going to be watching the recording, thank you for participating in this group discussion. Also, thank you for
It's
completing
Ali. Yeah.
your the overall survey. So we have kind of a tight timeline to get through a lot of these pieces, not just today, but in general, in terms of getting us to a point where we can have fruitful discussion in Boston. So we super appreciate everybody keeping the responses clipping in quickly. This is the end of round one. So we're going to look at the questions and talk about which ones are going to drop off at now that we've made it through round one. Our threshold is at 70%. So anything where we achieved consensus at 70%, you won't see in the next round. Um, so just that's kind of the nature of Delphi surveys. I'm sure you're all very familiar. Obviously, we've done a couple within CWIS. You'll see more. Um, Anything below 70% will remain in your question queue. The idea is that we don't change or adjust the questions, but that we get together at this point and just look at them. We're not intended at this time to be negotiating with or trying to sway other people
Mm.
in this meeting, but more so just to present the data so that people have an overall idea of what we did reach consensus on, where we did not reach consensus, and what that looks like overall, right? So that then as you take your next round, you of or as you look at the questions again in the next round, you have perspective for what people responded, as well as kind of the opportunity to consider your thoughts about the overall data. So, or about the overall questions. Um, so we're not going to necessarily argue or like that's not right or anything like that because there are very firm kind of guidelines against that in the literature, but more so just to present it like this is where we are. I think it's fine to certainly ask questions or if people have clarifying questions about, does anyone think this means A or B or something like that. I think all of those are fair questions, but no impassioned arguments about why one answer is probably arguably incorrect or anything of that nature. So you can see my screen, correct? We're all good? Fantastic. We were 100% that everyone agreed they would participate. Next question of what is your preferred term for the lower border of the well, let me just familiarize you with this overall setup. So this demonstrates, you can see there are a variety of data visualizations for the overall content. Um, we can pull up, in fact, I will pull up the the actual images so that we can see the images that Dr. Edwards created. Thank you very much for creating them. Um, let's get those up as we go through them. Okay, I will launch these ones as we go. Let's make sure these are appearing on the right screen. Nope, they're over on this other screen. That's not going to be super helpful to you. Okay. We'll make this a touch smaller so that you can still see the feedback. Um, not entirely
Sorry, it
helpful,
was
but you can see
complicated,
it.
but I hope it was understandable.
Super helpful. You did a
Good.
terrific job. So this green line is what we were assessing in this question. 98 there. I should also say in these first few questions, people could drag multiple responses, which is why there's more than 100%, as you all probably are aware and remember. But 98.82% of people agreed that this is in fact, or report that this is in fact a costal margin. So this question will, of course, fall off. You won't see this again in the next round. Any questions or thoughts? Perfect. Next one. Sorry, it takes just a second for these to load. So in this next one, we're looking at this red line here, or this series of red lines, I should say. Preferred term for structures indicated by number two. Costochondral junctions is greater than 70%, which by definition then would indicate this is our agreed upon terminology for what is represented by the red line. Any questions or discussion?
Oh, Sarah Ann, I
Yes.
might have missed it. Um, how many participants were there?
There was a total of 26, two people. They were all
26.
the people that agreed they wanted to be part of the work group.
Yes.
Two people did not respond.
Okay. So 26. Okay, thank you.
26 is our end, 24 is our actual respondents.
Oh, I see. Okay, yeah.
Yeah, two people didn't
Can
ever
we
respond back.
can we just look at the other histograms just to see what that looks like?
Yes. Oh,
Just move that
absolutely.
across
Yep.
very slightly.
Yep. So you can see
And
what
this is
what
presented
else.
automatically. It's really good.
Yeah. It's a really terrific system.
So
It's spendy, but it's worth it.
I've been invited today to take part in a UK guidelines Delphi, which Professor Ben Olivier and Kerry Battle seem to be involved in. So I'm going to ask whether they use this
Excellent.
system, and if not, it should be
Yeah.
recommended.
This was recommended to
Which
us
is
by
fantastic.
Center, which is a conglomerate of trauma organizations that we were invited to be part of. And this is the system they use and recommended to us. And it is not inexpensive on a per response basis, but I think it's really worth it. They have a really terrific, their
Mm.
visualizations are great. The way they give the data is great. I can download things in multiple formats. Like they do a really good job. So,
No, it's great.
yeah.
So Sarah,
Um,
this is, can
yes.
I ask, so
Please.
you're at 76% for this question, so we're just gonna move on. That's the,
We're
that's
at
the most
nearly
of our,
79%. Yep. So this one falls off. You will not see this in the next round.
okay, but when it comes time to discuss our findings in Boston together, will people have an opportunity to defend a viewpoint that didn't reach consensus, or is it done? You see what I mean?
Well, we could certainly do that. We could. But the consensus of the group is that we've reached I mean, the purpose of the Delphi is that we've reached
Okay.
consensus.
Well, the expectation is, even though you might have a really good idea or compelling reason, if the group, particularly if it's gone through 2 rounds, reaches a consensus above 70, then
Right.
that's it. We're done with that. Okay.
Yeah, we'll actually do 3 rounds total. But yes, the point is not to re-argue we have 26 questions. If we re-argue them all in Boston, we won't get through anything.
Mm.
Or in life. Like so, yeah.
Yeah, well, people are only likely to go, if you said choose one of these, what are people going to choose? I think
Right.
it's interesting, even so, in terms of the eventual discussion, when this gets written up, the distinction between joints and junctions is quite, it's an interesting little point just to have a sentence.
It's certainly something we can discuss if we feel, and there are some of them that
Yeah.
are, I mean, there are only, I would say, of the 26, maybe 6 of them that where we've reached consensus. We have a lot to discuss. So I would
Sorry.
say we take the win on the few where we came to a consensus because we've already got a
Absolutely.
lot to beat out. So next one, the yellow lines. We do not have a consensus. So here's an example where we are pretty evenly spread. Just as a reminder, the yellow lines are right along here. And we all feel pretty non-united about what those are going to
But
be
you
called
but you
or
may find, I mean,
what we think.
The whole point of a Delphi is for us to then look at what other people have said and think, okay, do I want to shift my opinion? And you may well find that it
Yes.
goes in the next round.
Yes.
And that if we can remind me when the date of Boston will be.
So it's on September 13th. So the
Okay,
next
so we got
iteration of this version or the next iteration of this survey will either come out tomorrow or Thursday,
yeah.
depending on how quickly I can shut the one questions off and turn the next round on. Then that'll be open for a week. And then we'll do the same process of looking to see where we have greater than 70%. And then we'll close those questions. And then those that we see at CWIS International, we'll chat again. And then the last round will start after that, and we'll close it right before we go to
Yeah, and
Boston.
you will find that there will be movement towards it. So,
Yep.
it's interesting.
Yeah. So we'll just keep rounding this out. Like I say, we'll have 3 rounds before we actually have the discussion. So there's certainly lots of opportunities to, have these conversations again and again.
and Joe puts a nice point in the chat about there seems to be an even split about sternocostal, sternochondral.
Yes,
Sorry,
it's a
there's a
very good point.
diversion there, but the difference between a joint and a junction seems to be very similar across the board.
I think so.
But we'll see what people say next time round.
Sarah, I'm going to call out Dr. Abbasi. We're having a little side conversation going on. I think he doesn't think he belongs in this group
Well,
because he
then
didn't.
would you like to assuage him? Or would
Yes,
you
This
like
is
me to
for
publicly
everybody,
assuage
isn't it?
I
him?
told him he's
This
definitely
is for all
in.
26 of us.
Would you like me
Is he
to
still on the
publicly
call? Do you
assuage
see
him?
is he
I
still on?
see his image, if that
Okay,
helps.
good.
Okay.
All right.
This
I'm
was
happy
intended for the
to.
whole group, I think, wasn't it?
This is intended for everybody.
Yeah, he apparently he had trouble with round one because of issues in Marrakesh. Can he still do round two?
Yes.
Okay. Ollie, I hope you
Yes,
heard all that.
indeed.
I
Can I
did.
ask a
Okay,
Thank
question?
you. Sorry, I'm in a cab at the moment on the way home, so I've
That
muted
is
myself.
no problem. I hope you're on speakerphone and your cab driver can hear this fascinating conversation.
Dr. Sparing has his hand up. Do you want to deal with that now?
yeah, Chris
I'm
is here.
sorry?
Hey, Chris.
Just one just question.
yes.
So
Please.
I think it's quite important to look into the discussion whether it's a joint or a junction. And you can
Yes.
see in the poll before that this seems to be unclear, or let's
Yeah.
Can we go
say
back one?
discussable. What I was thinking about while I was participating in this poll, what happens if we get the majority over 70% for your second question in, what was it? I think costochondral junction, and then on the other side, in the costal, in the chondral sternal area,
Yes, right.
we call it junction,
Yeah, I mean,
which makes sense at all. So where is or what's the time and what's our tool to clean this up?
Well, that's why
So-
we're having the discussion today. So this is the purpose of.
So I think
clarify this.
it will become apparent, but then the other question is whether we should, one of the questions we should consider maybe because the group can come back to this at the end. And if we have an issue like, what do we call this? This doesn't seem right. Why is one a joint? Why is one a junction? What we then look at is to think, well, okay, is the choice of the words joint or junction appropriate according to the conventional definition of a joint? So
Are they synonymous? Are they synonymous terms? They're not, are they? Exactly.
well, this is the question. I need to go back to different anatomy textbooks, and this is where we were lucky that in one of the early calls we had a university anatomist that Dr. Erickson pulled in, which was very useful. And I think she went to some of the anatomy texts to help with some of these definitions. So I think that we need to be aware of these emerging issues, and the difference between a joint and a junction is one of those. And we need to make sure that what the final article is consistent with established textbooks in terms of the definition of something like a joint. But thereafter, the problem is that we are going beyond, as we get to the later questions, well beyond the normal taxonomy that you'll find in an anatomy textbook.
Yeah.
But you're absolutely right, Chris. We need to make sure that we are, number one, consistent within the project, and number two, consistent with conventional taxonomy.
Absolutely. So I was just thinking, if we say on this question, because we will not see this question again because it's 78%, almost 79%. So if we don't see this question again and we say, okay, we call this costochondral junction, then we cannot ask in the next question costochondral joint again or sternal joint again.
So I think it is not contractually binding necessarily. I think if we then review the results at the end and we see that there is a clear error, then we can talk amongst the group to resolve that error. So
Okay,
I think
I was wondering if we were able to take out joint for the next round, if we call it junction in this question already over here. Because then the discussion is not about junction or joint, because we have decided on junction.
Yes, it's about costosternal or sternal costal. Yeah, I understand. Right. The question is whether we can do that quick enough, because that will require a separate discussion amongst the subcommittee that's put this together to review the diagnosis of the taxonomy, the definition of a joint and a junction as used elsewhere in the body. And that may take a little bit more time than we would like. So my proposal is that we do it in parallel, in that we carry on with the Delphi process as semi-automated, and we come back and we just make sure that the assignment of joint and junction is correct by other conventions.
So what do we do if in the next Delphi process for sternal chondral area, they all say 79% it's a joint? Because
we discussed it again.
Because in the orthopedic world, it's not a joint, but whatever. It's, I think we need to, at some stage, clean it up so that we, don't call the same thing junction and joint.
Dr. Abbasi has a comment. Is this a question of consensus or more related to anatomical accuracy? There's a fairly synovial primary, secondary, cartilaginous. So, I mean, he's correct. I mean, I think these all meet the criteria for a joint in that they are, so it may be that we go to joints, but as I said, I think we need to resolve this point by, in parallel, because this process, we want to get this done quickly so that we can move on to the other aspects of the project. I wouldn't want to pause for 2 weeks.
I get the compunction to get it done as quickly as possible, but we want it to be accurate. We don't want to have to redo this or have it be subject to criticism later. So I think we ought to settle that issue. But why don't we work through a couple more questions and then pause and see if those elucidate any other joint/junction controversies, because there's going to be a few more in here, I think, from what I recall. And is it possible, Sarah, to change the rules? So here's what I would say. Here's my question. If we wanted to redress this question a second time, can we eliminate the other answers and just ask these two, the most prominent ones? Or do you have to ask the question the same way the next time?
I think it's unconventional to change the questions in a Delphi. Dr. Bauman can correct me, because we went to we participated in the training together. So stop me if I'm incorrect, Dr. Bauman, but I believe the questions are supposed to stay the same.
Yeah, the questions are supposed to be the same. You can provide some information if you feel that a question was misinterpreted during round 2, but they are supposed to stay the same for all 3 rounds.
So we have done a training on Delphi as well, and I absolutely agree. The only thing is what you can do if you rule out this question we see right now, you can provide the information that the lateral part of the chondral area is called junction, or was like voted junction or whatever. So you can provide information. What you could also provide is you can, if there's a contrary in 2 answers of 2 following questions, then you can rule out one of those answers, which would apply in this area. but it's something that needed to be changed. But I agree with Tom to move on and see, because there was more questions about junctions and joints.
I'm fearful if we decide to use both those terms, because they may be accurate in one situation but not in another. We'll add a layer of complexity that's antithetical to what we're trying to do here. So I think we need to decide on one or the other. I don't care how we decide on it. We should use junction consistently or joint consistently. Would everybody agree with that? Okay.
That's what I tried to say, but I wasn't able to say that.
Okay,
So-
well then we'll keep rolling and let's kind of keep that in the, in the back, and we'll figure out where
We'll
that
come
goes.
back. We'll cycle back to that, I think, because
Okay.
I think there is an answer.
I suspect this will not be the last time we have that conversation. So we talked about that one. Or I think we kind of addressed this with that point, correct? The whole joint versus junction.
Yes.
This question is
Correct.
staying regardless because we're clearly not in consensus. Then we come here. We have a little more unanimity of thought. Let me pull up we got our image dropped to the back. Oh, no, don't go big. We got to nurse this thing to the top just a little bit smaller here to get it to fit so we can see what without making it go too big. Okay, so now you can see this. This one, these are the circled in red here, and you can see where we do have kind of a clearer leader per se, I guess you could indicate, but definitely not something that is winning out. We did have two people that provided written text for their responses, but they are different. So I mean, so the other two written text items, costal cartilage junction and costochondral junction, were two free-form answers that were provided for this item, I believe. Is this the right one?
So one other point that we may find out is whether, when we do this again, how much things change. Because it may be that this is the first time people thought about number 4, and when they go back to it, having seen 5, 6, 7, 8, 9, they may think differently. So it wouldn't surprise me if we see a little bit more of a left shift next time round, and it wouldn't surprise me if we need to go back to this and discuss this at some length.
Is articulation not another term that's desperately synonymous with joint and junction? So are we adding complexity here if we use articulation?
So I'm just going to throw a definition. A joint is a way that two parts of the skeleton are combined together, and I think that's a reasonable start in terms of the definition of a joint, and I think that starts to make the discussion about joint, junction, articulation a little bit more clear.
I think this definition that Dr. Shu provided in the comments
yes,
provides clarity as well.
I've not caught up with that.
Can you show us that, Sarah?
That's okay. Yep. It's
exactly. Okay. Oh, interesting.
Yeah, if you just click on the
Dr. Shu
comments.
just now.
So for those that can't see, I'll read. A joint is a structural and functional unit of the skeletal system, specifically designed for articulation. A junction is a transition or interface between different tissues or structures, not necessarily bones, and not necessarily designed for movement.
So is articulation a verb or a noun?
Both are, well, it's a noun.
Is it?
Articulate is a
I mean,
Is
in
the
this
is
context or in general, I guess those are different. You're asking it in different ways.
So Jeremy, where did that, that's interesting. Is that from an established, well-respected source?
it's
Well, it's
hard, like,
English.
because it
So, yeah.
comes from the like a wide variety of different like anatomy, like kind of references, like anatomy resources and stuff. So I think that you're going to find, I mean, if you want to pick the exact reference, I mean, I guess we could look up the exact either
Mhm.
lasts or Cunningham's or something like
Yeah.
that.
Perhaps so. Dr. Forrester?
Yeah.
Yeah, one question outside of the joint junction debate is when the next round of the Delphi goes by, are we going to remove do the lower frequency requests get removed or do those stay on?
They're supposed to stay on. The questions are supposed to remain as they came.
Okay.
But ideally, after kind of reviewing these and discussing them, not that we're intending or not that we're trying to coach people into shifting, but after having a discussion, having people be able to see kind of thought processes, the anticipation is that they would potentially we would see shift naturally.
Gotcha. Because the only thing I'd bring up is that in the terminology that we're using, we are not using all potential possibilities of a given term, right? So we have like side interchondral joint, interchondral synochondriasis, chondrosis, right? But we're not like saying interchondral side. It's just
True.
from
There
a
are
methodological
many
standpoint.
iterations of what it could be.
Yeah.
Yeah, that's a very good
Yeah,
point.
that was the problem. It got more difficult. And what I wanted to do was to give people the opportunity to make a distinction between the different patterns that I see on this type of diagram. And that's why I think we're allowed to say that's why I don't favor the most popular answer here, because I don't think it gives enough information. And I think the purpose, my thoughts around this process is to try and allow a higher level of differentiation between the different anatomies that we're looking at. So that's why my favored
Which
answers.
one is yours, John? The one you favor?
Well,
Articulation?
I personally like side to side side, because I think side to side is too complex. Otherwise, it becomes too much to talk about. So my preference actually is a side interchondral junction. Do we have that there? No, we didn't. I didn't put that down. In that case, I'm not sure what I wanted, but I like the idea of a one word for it being side rather than I call them side to side because that's what they look like. But I think side to side interchondral is a bit much. I like side interchondral. Then the question is whether a side interchondral articulation or a side interchondral junction or side interchondral joint. This is the problem. There's 15 different possibilities.
Well,
But personally, I like the idea of side, to make it as simple as possible, but as illustrative as possible.
So additionally, not to make the problem or more complex, these items
Oh,
were
please do.
also written in.
Yeah, exactly.
Now, is this what people will favor
These
because
these
they're
are
thinking
notes
about this and
people
looking at
wrote.
the map, or do they actually use these terms?
Well, these were other terms that people might want to use for that. We were offered, would you like to use something else? I like personally, if we're able to discuss this, I quite like the idea of synchondrosis because it is more Latin and therefore with different languages, it may be more appropriate and understandable.
I'm not sure if we're
So
smart enough
maybe it
for
should
that
be
in
a
our country,
lateral.
Dr. Edwards.
I know, but but we do, but we still use terms that derive from this. So maybe we should have included their lateral synchondrosis.
Okay.
So, sorry, can may I make a comment? If I may, um,
Ollie, you sound like you're in the bottom of a pool.
John, I take what you, but often these anatomical descriptions are. Can you hear me now? Does that make any
That's
difference?
a bit better.
Yes, a little better.
Okay, cool. My point was to say that whatever terms end up coming out of this, a lot of it is going to be very relevant to radiology because we're having to describe what we're looking at on the screen and being able to convey that in a report. Now, just to give you a little bit of insight from a radiology perspective, these scans, I'm reporting a lot more of the CTs now for Ian Hunt. And they take a long time to report. The reason I'm here at 9:30 back from work is because I reported 3 CTs and each took about 45 minutes to an hour. If the terminology is very complicated, it makes it really difficult to convey the information and it will make a very wordy report. And that's in spite of the fact that we're keeping it relatively simple with interchondral joint, which is what I think 63% of the respondents have said. If it really makes a big clinical difference to distinguish between an end and side and a side to side and a side to side synchondrosis, then I would be far more amenable to doing that because then it would have a clinical relevance in that, I'm going to fix it in this way or I'll do X this way. Then I think then a person would be far more conducive to taking on that taxonomy. But if it becomes very complicated, even if it's anatomically correct and there is consensus, from a practical perspective, it's very difficult to implement, then you might find that the take up of it won't be easy. It will become very difficult. And therefore, my 2 pence worth in this would be say we should only be doing things that have clinical relevance, i.e., it would impact on what you might do after if it was an end to side or an end to end or a side to side. If that really made a difference, then that's fair enough.
Absolutely, and personally, I think it does make a difference. So I think if you've got, at the costal margin, the 8th to the 7th is a side interchondral joint rather than an end or whatever you want to call it. I think that does make a difference in terms of surgical options potentially. So I think it does have clinical relevance, and that's why I chose this very scan, because it has a lot of variety to it.
This is all very interesting information, and it's amazing to see the difference in amount of responses we're getting, even from people who think about this on a day in, day out basis. And I think that's the most interesting part of all this to myself. Given that we're 36 minutes into a 30-minute meeting, Sarah Ann, let's move this forward a little.
We do need to keep going, and I really appreciate everybody's thoughts.
And then we can kind of see where the common and different areas are at the end and hash it out a little bit.
Yep. Well, so again, no unanimity of thought here.
It's the shortest word.
For all the same reasons that we've talked about. I do need to see the image, or do you know where we're talking? It's the screen. This one in this case is what we're, just to make sure everybody's on the same page. And this is where we stand.
We can move on straight away, I think.
Yes, you'll all have the opportunity to see this again in the survey shortly. So that'll be great. This one, again, we just have a lot of work to do. We've have agreed on this one. So the light blue, I'm going to try to make this easier to see. This little guy right here, and quite a bit of variety of thought. So not surprising that we are doing this project. This one is the purple component, which in this case is right down here. And maybe getting a little closer to some commonality of thought. Let's move this guy over here. our dark red in this case, oops, oh, we'll put it up here for now. It's just this one right down here so that we're on the same page. And you can see, again, pretty spread across. Now, again, you'll see these in the next couple days.
So again, we've got joint articulation, junction, but the idea of tip interchondral something is the winner by far. So
yes,
this is where we need to resolve the joint articulation junction arguments, and then we will have consensus, in my opinion, there.
I would imagine so.
Which is good. So actually, we're close. We're close to getting something.
Yeah.
This one is looking at this black circle down here. You can see my cursor right down there, number 9. And everybody's calling it something different by a wide margin. So we're not particularly close there. This one pretty close. Obviously, we're at 68% here. I suspect that this will come to 70%, in the next round. So I
show us that
imagine.
image, Sarah.
I'm sorry?
Show us the image that we're defining.
There's no image directly
there's no image. It's the definition at the top
just
there.
when considering a costal
Yeah,
cartilage, which does reach the sternum directly without some form of joint or articulation, the cartilage above, what is your preferred term?
I mean, you're all
Well, it's a
wrong,
little
but you're good with it.
Well, okay, sorry.
John, we're not supposed to be influencing the crowd.
No, I know. I'll shut up. Sorry.
I have a strong feeling about this one as well, but I'm trying to keep my lips shut.
We'll commiserate together in Brussels.
Yeah, you and I may be 100% aligned or unaligned. We'll see.
When considering a costal cartilage, which does not reach the sternum directly, but has some form of joint or articulation with the cartilage above, what is your preferred term? Again, false rib is at nearly 64%. So perhaps we'll reach threshold on that in the next round. If not, we'll continue to pull it through to round 3. We'll see.
It's great
this one
to see.
I think is interesting. Preferred umbrella term for painful conditions of the chest wall. It looks like the word disorders is kind of the preferred word over the other versions that we tried. But it's a matter of do people align more with functional versus painful?
I mean, I'm really pleased to see how this is going, because it was
it is interesting to see here that these are so close. These are so close.
I mean, ultimately it's so good,
right? Like
it's so good to be able to draw a line in the sand and then and then move on. It's really satisfying to see.
It is. It's a very interesting. It's interesting to see how people think. This one, do you recognize or use the term unstable sternocostal joint, or do you prefer another term? Again, close to consensus, but not there. Let me pull up
So this is all the difference. So now, from now on, people, this is just a whole series of different functional / painful chest wall disorders. I mean, obviously, this would be unstable sternocondral junction, if you prefer. But either way, this is more about the entity that aligns closely to the term that we choose.
So the other options that were expressed, or that people use in this situation, let me make sure I'm pulling the right ones here. Okay. The other phrases that were expressed are hypermobile sternocostal joint, unstable sternocostral, costosternal instability, costochondral dissociation, hypermobile costochondral joint, and unstable costochondral junction.
Can I ask a quick question for round two?
Please.
Is there a way to, do we need to show those? Can the test taker take those? Because there could be, in theory, a term that somebody's like, I never heard of that one, but I really like that one, and that could be the consensus. And if we don't throw it out there for people to see, out of sight, out of mind type thing, I guess I don't know. I don't recall Dr. Price ever mentioning that in the others when people are writing it in, and how to address those.
That's
I
a good
think
point.
that's a very good point. I think we could, and well, I think you can read the comments. I think you guys can see these when when you're reading them. I think if you click into other, I think you can see as you're reviewing, when you get the next round, I think you can see what the comments are. We're not showing, I mean, I'm not visualizing them today because they have people's names associated with them, but yes, I think you can do that. And I think if we don't reach a consensus, for sure, it's something we'll have to discuss in Boston, or we could do a separate questionnaire about it. That's
So
certainly an option.
does the system produce an easy output? I mean, it produces these amazing graphics, but does it allow us to to produce an output with those text options? We saw the graph there, but there were 12 that were the same, and then 3 that were different, and 4 that were something else. Is there a way that we can then produce an output that when we do the second round, we can see the numbers of different options that people gave?
I believe in the second round, you can see what people have responded in the prior, but why don't I double check? If not, it's something I can pull and send to you in advance that you could have as you're answering.
Because I think we should be able to see, even if the system doesn't allow it, if we see that there is, Zach's stellar answer that is in the comments, and if we all go for that, then that's the winner for round 2. But it might not necessarily be designated as an option to choose from. But if we see the text options and we think, yeah, that's the one I want, we can type it in. And if we then see that as the 70% option in the next round, then that's the one we have to designate the winner. So I suspect the explanatory text that we send in an email is that if you see one of the other responses from round 1 that is the one you want to choose as your number 1 option, you click other and you type that one into your round 2 response.
Okay. Do you recognize or use the term unstable costochondral joint?
It's going to be the same, I should think, in terms of the different options, isn't it?
Yep.
So we can probably move on.
Do you recognize or use the term manubriosternal arthropathy? That's probably how you say that, I bet.
So again, when we see the other options, there may be one that we prefer there that we haven't thought about for some of these things.
Bam! Reached consensus. Do you recognize or use the term costochondritis? Or do you prefer another
We
term?
know what it means.
Who's the mook that said no? I'm just joking.
A lot of people.
That's a privacy question.
20%. 20% said no. So is there just out of interest, is there a list of other terms in there?
No, they didn't. There were no other terms. There were just people who don't use it, but they did not provide.
Doesn't matter.
Right.
Doesn't matter because it's out.
To recognize
Tsetse
syndrome.
Is it a syndrome or is it a condition?
Can I be slightly awkward here?
Please.
Radiologically, a lot of these patients don't actually have cartilage inflammation. And I went through the literature. I went back through the literature, and a lot of this terminology of costochondritis comes from a solitary histopathological paper from the 1970s, I believe, which mentions that the cartilage has some inflammatory cells. But if you look through the cartilage doesn't really inflame. It doesn't really inflame. There are not cells of inflammation within the cartilage, be that acute or chronic inflammation. And inflammation has a very set definition. It has to have the presence of very specific cells, very specific, biochemical parameters. And the cartilage itself does not have the ability to inflame. What does inflame is the perichondrium. And so in most of these cases, these patients actually have a perichondritis. And then radiologically, they don't behave like a costochondritis, because when you give them intravenous contrast, the cartilage does not enhance. Whereas if you look at an inflamed joint, infected joint, or infected anything, one of the things that happens, of course, as part of acute inflammation is that you're meant to have hyperemia, right? That's the rubor and the calor bit of inflammation. Well, that just doesn't happen in cartilage, so it doesn't enhance. So we don't really see a true chondritis. And if you look in other conditions which were traditionally called chondritis, so for instance, chondromalacia patella, which used to be called osteochondritis dissecans, the cartilage doesn't really inflame. It's a chondrocyte metaplasia rather than an inflammatory condition. So that's why, technically speaking, sorry to be incredibly awkward, the reason I moved away from using costochondritis is because it doesn't really inflame.
Perichondritis.
Wow, that's fascinating. So why you're here, Ali? Fascinating.
I like it.
Wow.
I absolutely get all that, and I think that's really really interesting. And it's almost deservable. I mean, it's deserving of it. The problem being is that costochondritis is almost a universal term. Patients use it all the time. Primary care physicians use it all the time. And it will, it's like flail chest, isn't it? I remember when we did the taxonomy for the rib fractures, it was the F word. There were so many people that were so against the concept of flail chest because of multiple reasons. To be able to change what is effectively universal practice will take a great effort and great understanding, and that is, what you've said in those statements is absolutely fascinating. We need to be cognizant of that. We need to work out how we incorporate that in a document. And I suspect that should be a significant caveat in a manuscript. But can we change the opinion of the people responding in this process? Don't know.
Yeah, no, I take that on board, and I actually agree with that. We've had this problem.
Interesting.
We've had the same problem with bone marrow edema, which I think everybody in this group has probably read that in a report. But bone doesn't really become edematous. And so for many, many years, for about 30 years, people have been saying we should call it bone marrow edema-like signal is what we're meant to be using the terminology. But I am very much in the minority of people that use that term. Almost universally, people will call it bone marrow edema, when in reality, it's very, 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 very unlikely to be edema at all. It's usually trabecular remodeling, fibrosis, etc., etc. But it's become, as you say, it's the accepted term internationally. That's what you'll read in every report all over the world.
But equally, it's an acorn. This is an opportunity to grow something. And if we start using the term costochondral perichondritis, is there a better one? I don't know. But we can. That's something that can be an outcome of after the end of this. That this is not necessarily going to be the end of the process. And I think it's very important that we include that caveat thank God that this process is recorded, because your your description there can literally be cut and pasted into the paper, I suspect. So, but yeah, I think we have to do what we do with the process, and then write some caveats and explanatory text around it.
I just have one request, that we use the term acorn and growing this terminology in the manuscript, please, John. Just make sure that we use that.
Absolutely.
On it.
There are other seeds available.
Love it. Do you recognize or use the term xiphodynia, or use a preferred term? 95% say yes, so this will fall off before the next round. This one is fascinating to me. Do you recognize or use the term slipping rib syndrome? Obviously this didn't make the cut. However,
Good.
multiple other options were suggested.
I need to take issue with the question. I recognize it, but I don't use it. Or you could
That
use.
is true. Yeah,
So-
there are some.
Can we restate the questions, or they have to be exactly stated the same when they go back the second time around? Do you
There are
favor the
s-
use of slipping grid syndrome, or do you prefer something else? Everybody recognizes it.
Okay.
But-
Yeah.
So
Yeah.
are we
What do you
able
think
to-
of the term just slipping ribs, Tom?
slipping ribs?
Slipping rib versus slipping rib syndrome.
Sure. Well, there's a question related to that
I think
coming
there's a
up.
different.
Yeah, it's more specific. But I think the recognized thing here is confusing, may have confused some people. I don't know. Confused me.
Yeah.
So let's
yeah.
Let's rewrite the question so it's a little more clear. Do you acknowledge, or do you favor the use of the term slipping rib syndrome?
I
Or do
think
you
I like favor. I like favor. If we can use favor, as long as we can include a U in favor.
Yeah, we can spell it your
Definitely
way.
not. We're on the other side of the pond. And point two, I think we've talked about changing questions.
Yeah, isn't it ironic that Dr. Abbasi is lobbying for shorter terminology, yet they spell all their
When they like longer words. I
You-
know. I find it to be curious too.
very
I
interesting.
do. There's a lot of irony to that situation. You can see the other answers. Slipped rib cartilage. Someone did prove out your point, or maybe you wrote this. I recognize the term slipping rib syndrome. However, I do not think it's accurate. You probably wrote that. Subluxing rib syndrome, subluxation, costal cartilage disruption, or subluxing rib syndrome. It's not a good term. Hypermobile rib syndrome.
So we're not supposed to talk about this, but the point about subluxing is that, again, subluxation has a clear conventional definition compared to dislocation of a joint.
I feel like you're not understanding the rules.
I know, but I will just pour myself another glass
There are
of wine.
rules, and you aren't getting them. So
know,
we're gonna move along,
okay.
and we're gonna come back to this in the next round.
All right.
Adore you, so
I'm
adore you.
gonna catch up, with John.
Oh my stars! It's not even 5 o'clock here.
I don't have any responsibilities except this. So
Okay. Do you recognize or use the term unstable true interchondral joint syndrome? 40% yes, 55% no. Other people wrote comments. So there's that.
So the difficulty here is that we're assuming that people like the term true interchondral joint. And
Right.
we're making, the
What they
assumption is
decide.
that they can,
I think in
the
fact they
assumption is
don't
that they
favor
can go
that.
back to that picture. Perhaps it should be the term unstable number 4 joint.
Very possible.
So again, I think in terms of the text that we put in separately, because I think it needs just a little bit of clarification if we cannot change the whole question, that is about joint number 4. So what do we call an unstable number 4?
We can definitely add a comment, a clarifying comment. Like if you want to be the first person to respond, everyone can see your comment.
Yeah, so I think that
Um,
that would be my point for that last question is,
yes,
what is an unstable number 4?
yes.
Um,
Do you recognize or use the term rib tip syndrome? We're pretty fairly split here. Um, do you recognize or use the term costoiliac impingement syndrome? Even split. This one I think is interesting. So, and this is something Dr. Erickson and I have discussed a bit, and I know Dr. Wright and I talked about it as well. How should the excessive pathologic movement of costal cartilage be defined? Since we have two that reached more than threshold, theoretically this question would close, and then we would take this to Boston and or offline somewhere, and we would define what's the difference between mobile and hypermobile, right? Because
wow.
clearly people see a difference, or they feel like there's a definable difference or discernible difference. But two did reach threshold. So that is the sort of technical process that would occur. But any thoughts? Would other people agree that there is a
Well,
difference
the way you
between
asked the
mobile or
question,
hypermobile, or that if we accept both of them, we need to define the difference?
I think it's that. I think
Right.
we need to make some attempt to discuss the difference between mobile and hypermobile, and this is where I mean, it's really interesting. I need to talk to our Viking friend about this in terms of the cadaver studies. I've in the cadaver labs I've been doing recently, I've been looking at the mobility of the costal cartilages, and how they slide one against another. I haven't yet. I've managed to get a couple of videos from cadaver labs, but some of them are a little bit jumpy about me taking videos. But it's really interesting to see how these the cartilages slide along. So how do you define mobile and hypermobile? I think is a really interesting question. We can
well,
start
in
that
my mind,
conversation in Brussels over a beer.
I mean, cartilages are designed to be mobile,
Of
so that's not
course.
necessarily pathologic. Hypermobile connotes excessive movement, pathologic movement. It's in the definition up there. So I well, I think it's a good one to argue about. But I think hypermobile is what we want to say.
Well, they
Yeah.
both make thresholds, so we'll define what if there's a difference and if we keep both.
Interesting that slipping and subluxation did
Sarah
not.
Ann, since
Yes.
this meets consensus and is going to get dropped for the next round, can we
Yes.
choose to keep this question and limit it to only one answer and see what we get in round 2?
I think
Just
we
for
can do that.
curiosity's sake of what is the most popular of this among the group. Because
Okay.
it appears mobile's more popular, but if you made people choose only one, that may change. And I know we're changing the survey, but it's already out, so I don't feel bad about changing this for that reason.
Okay.
So I think the Tom's point was really useful. The fact that these cartilage is mobile, and so does hyper equal excessive. And I think there's not a problem with us having a little bit of commentary about that, is to ask people to think, given that we can say that given that cartilage is mobile, does that alter your thought about whether excessive should be mobile or excessive should be hypermobile?
I like Everett's idea of including some questions that may not be technically legal from a rule standpoint, but leaving them in, and then we can do what we want with the answers later. They don't necessarily have to fall into the
So Ali has come up with a comment. Problem with hypermobile is that hypermobile subluxing rib patients are a distinct cohort in those with connective tissue disorders. Yeah, I get that. I mean, hypermobile Ehlers-Danlos has a definition, doesn't it? I'd need to look up. has anyone actually, what's the history of the definition of hypermobile EDS? I mean, there's the Baton criteria that you use to determine whether they have hypermobility, but that's different to, I mean, that's a score, isn't it? Where you have 6 or more out of 9 that is defined as hypermobile. So, yeah,
Thanks, Greg.
interesting.
And last but not least, is there a non-oncologic rib or cartilage disease or syndrome that we have missed? We have a few things.
I'd be interested in the text for this.
The text
Well, I know there's some
is listed here.
There's some pathologic ossification syndromes that can involve cartilage.
So these are the
Well, I saw my patients with the 8th costal cartilage tip in the middle of the rectus abdominis today, which is very symptomatic, and I've never seen that before, which is fascinating. It's literally sticking in the middle of the muscle, and I've never seen that described. I need to write some case reports. I'm useless at case reports. Hypertrophic cartilage non-union. Yeah, okay. So these are, some of these are more traumatic. Yeah, so someone says it's important to distinguish traumatic versus non-traumatic. Yeah, interesting. There's a lot of interesting stuff there. Ooh. Friction syndromes.
Hey, friends. That's what we got.
So what are we going to
do? Yeah, so what's our plan? Re-administer the survey.
Boy, if I knew. Yeah.
Wow.
Yeah.
So I think with the new survey, when we send it out, we need to send out a summary of what met threshold and was taken out, just so people are aware in case they weren't on this meeting and whatnot. We need to level the playing field for everybody who isn't necessarily here. So I think at a bare minimum, we need to have a short summary in the invitation to take it again that says these 6 fell out and these were the results of those questions.
Absolutely. So there, I think that's the point, is that there were questions which reached consensus. The other big issue.
Any graphs? I mean, do you want data visualization with them, or do you want just stated items?
I think it's reasonable within the boundaries of the methodology to, if there is the ability for the system to produce a PDF output, I'm sure that there must be surely that will allow us to just look at what everybody's done before we go back and answer, because I think it's useful to know that for respondents to see the later questions before they answer the earlier questions again. So I think they need to see all the results and then go back to the beginning and go through.
I'm sorry, if you want to see all the results?
But like we have
done now. Or you just want to see the ones that fell out?
No, I think people need to see everything.
They will see, like, they will see all these results when you retake the Delphi study, you'll see what everyone else picked. You'll see what all these percentages, like this bar graph. You can look at all that, and that'll or next round decision making when you get asked a question. The only ones they won't see are the ones that have already reached consensus that we're pulling out.
So this is where I think, you know, if even if it's doing a cut and paste PDF, I think it would be, you know, it would be helpful for people to know the answer to question 12 before they answer question 2, for example, just in case it changes, just to make it more harmonious in terms of the way that things are answered. If they know that there is an argument about joint versus junction coming up, it may help how they answer the earlier questions in round 2.
Okay.
And I think it's also worthy of highlighting the issue about we've got a problem with joint versus junction versus articulation. And I think it is, you know, the text that Jeremy has helpfully supplied is possibly as good as we're going to get. I think it would be worth, Everett, talking to your anatomist and seeing if she's able to write some very brief paragraph, you know, a sentence about the anatomist view of a joint versus a junction versus an articulation. That would be extremely helpful for us to see that and read that in an email before we answer again.
Okay, we can take a look at that.
Can I share an anecdote with
Hi,
you guys?
Dr. Abbasi. Thanks
Go
for
on.
joining from the cab.
Black cab.
If you think this is hopelessly complex, let me share a little anecdote with you.
No. Don't go on to your next point until we resolve this. I know where you're going, but don't distract us yet. Again, big heart energy. Yeah. Lots of big heart
But
energy
I
for all
think
of you. Do we have anything else that we need to resolve related to this?
so. I think it would also be useful for us to see the other responses,
The comments. Okay.
the comments, so the text comments for each question, because, you know, there are some where the other was a substantial option, and then we may see the you know, the Bauman bomb that may just come up with the winner.
Strong writing candidate. Okay. Okay. I think we've wrapped up this portion. Dr. White, share your fact.
No, it's not that interesting.
It
It's
is that interesting. I know exactly what you're sharing, and I
Absolutely.
think it's fascinating.
Okay. So this
Okay.
seems complex, right? So
It
yesterday
is.
I wanted to see how many possible combinations of rib fractures there are in the human body, taking on
There we
a
go.
couple assumptions. 24 ribs, 12 on each side. Each rib could be fractured in up to 3 places, and any combination of rib and any other rib in any number, any combination could be included. So what do you think the number is of possible combinations? Now, of
Oh,
course,
it's
not
going to
never
be,
practical. You're not going to fracture the left first rib and the right seventh, and then, or you might, but that would be a rare combination. But all possible combinations of rib fractures, how many do you think there are?
are there more stars in the universe?
There are more atoms. There are fewer atoms in the universe than there are combinations. It's 6.1 times 10 to the 103rd.
Wow.
And that doesn't account for different fracture types. That's just 3 ribs, 3 possible rib fractures in an individual on 24 ribs, but any combination is apparent.
That makes it astonishing. That makes it astonishing how there are rules, there are anatomical rules that dictate how fractures occur. Because it's not there, because that's random. You're saying this is the random distribution, these are the random opportunities, and we don't see those. And so what that indicates is that that anatomy and in its wide terms affects the probability of different fracture patterns.
Sure. It also suggests to me that you'll go through your whole career and you'll never see or operate on a patient who has exactly the same fracture. You'll ever see somebody that has the same third, fourth, fifth, eighth fractures posteriorly with one fracture on the other. I mean, you're just not going to see it. It's too rare.
Or maybe not, because maybe the patterns are dominated by anatomy into subsets that are actually quite common.
Yeah, maybe. Okay, I'll buy
It's
that.
fascinating. It's a similar thing in terms of the lung cancer distribution in the screening trials is also fascinating, in that I think it was the Nelson trial, the Dutch study of lung cancer screening. You would think that because there are 19 segments, you'd think they would all have a relatively even chance of getting a lung cancer, and yet 38% of lung cancers in the Nelson trial were detected in the right upper lobe, which is a lot more than you'd expect by pure chance. Really interesting. And I'm going to pour myself another glass of wine because it's empty.
So Chris, being a surgeon, not that hard. Just one femur. It's got one break. Typically, it's his one femur is just pretty much like
Don't
the
let
neck.
him give you that. You just flip
But
him
ribs-
right off right now.
Ribs are much harder. They're much more complex.
Just give him one of these. I'm done.
Well, there we go. Anyway, really, this just makes me more excited for Brussels.
Just you wait.
Oh, it's gonna be great.
He's gonna whack you upside the head in 9 days, and it's gonna be deserved.
It's going to be a lot of fun.
9 days. It's only 9 days.
Wow.
Oh my goodness.
I know. It's only 9
Wow.
days.
Well, it is for you when you travel, but it's maybe 10 for the rest of us. But
9 days,
11,
which
yeah.
means there are like 97 things to do. So I love you all. I'll see you all there. But for now,
Can't
I'm gonna
wait.
go get some things done. And
Can't
Bye,
wait.
everybody.
Bye-bye.
Great to see you.
This has been the most interesting Zoom call I think I've had with CWIS. So it's fantastic.
well,
Really
that's
good.
true.
Great
Always
stuff.
true.
Take care.